Hello and good evening to you all. Happy to be here again, of course. And as always, please let me know if you can hear me. Hi, Dr. Thomas. Hope you can hear me.
Yes, thank you.
Perfect. Hi, it's good to
Hi.
have you here with us. I am your host, Caroline, and again, we are meeting here today for our online patient meeting. And of course, let me remind you that we are gathering here twice a day from Monday to Friday, recently, simply so we can give you option to meet the top experts from in the fertility field, but also so that you can get connected, get in touch with those doctors, but also you can simply find out on so many different aspects on IVF treatment. So as now we all are just waiting for the good news that we will be able to go back to normal and simply start our treatments. So this is all for you. And of course, it wouldn't be possible if it wasn't for our ambassadors and partners. You can all see them right here on the screen right now. And thanks to them, we were able to simply start our initiative, Stronger Together. So again, huge thanks to our partners and ambassadors as well. And I already have told you we are here with Dr. Tomáš Rieger from Gynem IVF, which is located in the Czech Republic. And he is an embryologist, their head embryologist at Gynem. And so, of course, today he will be talking about embryology lab, of course, on so all kinds of IVF lab techniques and procedures he will be able to explain to you. He will start with a short introduction. We will then go for the most common questions, and then it will be your time to ask questions. So again, feel free to ask your question. It will be answered by Dr. Thomas. You can type this all in the chat section. And all of this is being recorded as well. All right, that will be it from me. Dr. Thomas, ready?
Ready?
Perfect. Go ahead.
Hello. So, my name is Tomáš Rieger. I am head embryologist in a Gynem clinic, as was mentioned, which is situated in Prague. And we offer to our patients all the basic and special techniques which embryology labs can do, as pre-selection of the sperm, ICSI or IVF fertilization. We have a spindle observation system, which we can do the precise timing of fertilization. We can cultivate the embryos in time-lapse monitoring systems, which can help us to choose the best embryos for transfer. We can do PGT testing focused on aneuploidy, monogenic diseases, structural rearrangements. We usually cultivate the embryos in the blastocyst stage, which is the best stage for transfer and freezing as well. We have a few methods what we can do extra in a process of transfer, like laser assisted hatching or using of embryo glue. We can help some patients who has poor results in classical IVF culture systems, that we can use embryogen and blastgen, which is mediums where is edit contains some cytokines and growth factors which can help the embryos to develop better. So all these things we are using in our lab, and about all these things I can answer whatever questions will be ready. So that's like basic introduction from me. So
Right.
we can start with the questions.
Mm-hmm. Perfect. Thank you so much for the introduction. And as I've mentioned, now we will go to most common questions from patients. And let me have a look at the first one. What preselection method is optimal for me?
Yeah, Thank you. Regarding the pre-selection methods, the most important thing is quality of the native semen sample, which we will get from the patients on the day of fertilization. According to the quality of the sample, we can choose from 4 main pre-selection methods which we have in our lab, but some of them are focused on sperm, where we have many of them, like more than 1,000 millions per milliliter. Let's say fertile chip and max system, these two methods. Fertile chip system or like pre-selection method, which is focused on the best movement of the sperm. Every pre-selection method has some logic behind it, and fertile chip is focused on the motility, because the logic is that when we are doing everything as in the body, only the sperm with the best motility can get to the oocyte. So like from some biology background, we believe that the sperm with the best motility, best movement, is the one which has the best chance for fertilization, and hopefully for the good developing of the embryo to the blastocyst and future healthy child. So this fertile chip is focused on the movement, but as I said before, there has to be minimum 10 million motile sperm per milliliter. Second method, which is important to have good quality sperm or many sperm in the sample before the method, is the max system. This system is focused on dividing the sperm which are designated to apoptosis in the body, because the body itself has few systems how they can solve or like see if the cells inside are good or bad. And we, like all human, have these systems. One of the system is phosphatidylserine system, which can be marked like the bad quality cells or sperm as well, but it fits on all cells in the body. Can be with white cells, can be somehow checked, and if they are not good enough, the white cells will do some extra mark on this cell. This mark is a small molecule of phosphatidylserine, and then another white cells which are going through the bodies, and they are looking for some cells which are not good enough for the body. When they see the cell marked with this phosphatidylserine, it will eat it, it will destroy it. And this system can be applied on the semen sample, and we can divide the ones with this phosphatidylserine mark on it. This can be put away, and only the sperm without this mark can be passed on and follow to the fertilization process. So this is the max system, and there are 2 more systems or pre-selection methods which can be done even with lower quality of the semen, with small numbers of the semen of the sperm in the semen sample. One of them is Pixie method. Pixie method is focused on maturity of each sperm, and for the Pixie method, it can be done on, let's say, on 100 sperm. We don't need some thousands or millions. And the Pixie method works that there is a drop of hyaluronic acid, which is quite common molecule in our bodies, and in the fertilization process, this hyaluronic acid is also covered. The oocytes has some hyaluronic acid covered in the surrounding cells, and the sperm has to, in normal fertilization, the sperm has to be attached to this hyaluronic acid for the process of capacitation and then acrosome reaction. And when the sperm doesn't have this receptor ready for the attachment to this hyaluronic acid, this sperm cannot fertilize the oocytes at all. So this method is can show me which sperm has this receptor on its head in a good quality, and these sperm can be then used for fertilization. Of course, nothing is optimal in the life, and there can be mistakes. So sometimes we can see that on this hyaluronic acid, also sperm which doesn't look really well can be attached. So the logic is that if the receptor is there, the sperm should be fine. But as I said, nothing is 100% optimal in bodies. So this method is maybe my least favorite, but somebody has good results with it, so we have this optional method as well. And the last method which we can offer to patient is IMC procedure, where this method is focused on morphology quality of each sperm. We can magnificate the sperm up to the 6,000 more than normal, which can allow us to see inner quality of the cytoplasm in the head of the sperm, and we can see some problems in the shape of head, on some morphology issues in the neck, in the tail. We can see vacuoles inside the head and all these stuffs. And of course, when we have many more sperms, and some of them has some problems, some morphological issues, some vacuoles in head, and some of these sperm are looking nice, how it should be in some morphology atlas, we of course choose the good-looking sperm, the perfect-looking sperm. And the logic behind it, again, is that if some sperm looks how it should look, hopefully the DNA, the genetic code, will be fine as well. Unfortunately, none of these methods can show us the genetic information itself, which will be the most important thing, of course. But there is no method now in the field that can show us genetic information and not destroying the sperm. We have methods how we can see genetic information, but we have to destroy the sperm. So in this time, we doesn't have any methods like this. Maybe in future something better will be developed. But now we have these 4 ways. Still, with each sample, we can do more techniques on the one sample. We can in the first let the sperm goes through the fertile chip, which is like small maze made from tunnels, and it should mimic the fallopian tubes, because the sperm has to go through the maze in the fallopian tubes. And we can put the sample in the fertile chip first, the ones which will get through the maze. Then we can maximize or like magnify with the IMC procedure. We can put them on the hyaluronic acid, so we can do more of these pre-selection methods. So with each sperm, each sample. But of course, some of these methods need some centrifugation, some additional like work in the lab, and of course it can be a little bit stressful for the sperm itself. So it always has to be counted to do as less stress to the sperm and choose the best one from the sample. So that's how it is. Every sample has different quality, and we can offer and recommend different strategy how to check and how to choose the best sperm for fertilization itself.
Perfect. Thank you so much for explaining all the details and of course all those methods. We will go back to those methods a bit later on as well. But now let's have a look at this one, okay? Can embryoscope time-lapse embryo monitoring help to select an embryo? Would it help in terms of embryo development and quality?
Yeah, the embryoscope or like time-lapse monitoring systems, because the embryoscope is only one of them, and we in our lab have 2 different systems. So the embryoscope is maybe like Mercedes between them, but it's not like the only one. But all time-lapse monitoring system can get us useful information about the development. The major plus of this method is that in classic cultivation we have the embryos in the same well. Let's say we have 6-7 embryos in one well, and they are still developing all these 5 days. And after these 5 days, this is like standard incubation. After these 5 days, we see that there are like 3 or 4 good-looking blastocysts. We will choose them, one of the best one for transfer and the other one for freezing. But in the embryoscope or the other time-lapse monitoring systems, all the embryos are cultivating in separate wells. So we can perfectly tell after these 5 days of cultivation, how does this concrete embryo, this special embryo, develops whole time for whole 5 days of cultivation. Because it can sometimes happen that, let's say, on the 5 days, 3 embryos looks pretty much the same. They have good quality blastocyst, and when we have classical cultivation, we only select one of them a little bit like accidentally, or like by just like what my eyes favorize on the moment of transfer. But when we can see the time-lapse footage of each embryo, because these systems makes every 10 minutes picture of the developing embryos, so after these 5 days we have like a whole movie about this development of each embryo separately. And then I can see that, let's say on the day 3, one of these embryo was the fastest one, and the second and the other 2 was a little bit slower, and then they can like reach it up. They can be faster in the last 2 days. But when I need to choose the best with the embryo with the maximize the implantation potential, it will give me the chance to choose the best one, because these kinetics and this time of splitting, speed of splitting, the quality of splitting of the cells, the time when they reach 4th cell stadium, 8th cell stadium, modular stadium, the quality of the trophectodermal cells, inner cell mass, all these things can be precisely checked in this time-lapse footage, and it allows me to choose the embryo with the highest implantation potential. So this time-lapse systems are definitely worth of using. If I will undergo this treatment, I will definitely use it.
Okay, perfect. Thank you so much again for explaining this to us. And now we will go back to the IMSI Pixie Max question, but perhaps you can add something to this. So what you can really do in the IVF lab if male factor is involved, and if you have like a preferred or some method that is the best in your opinion.
Yeah, like it depends. Like on the, as I said before, it depends on the basic on the starting quality of the semen sample. When we call male factor, it means that the sperm are not in the norm usually. The norm says regarding to last WHO statement that it has to be more than 15 million per milliliter, more than 40% of the sperm should be motile, there should be less than 96% of pathology of the sperms. So in this like normospermia, we can leave it how it is, because we can see millions of good-looking sperms with good movement. Of course, we can use some of these pre-selection methods, as I mentioned, the fertile chip. This can be used with the good quality sperm anytime. But if we're talking about male factor, it's usually semen samples with only hundreds, thousands, maybe 10,000s of sperm, but a few millions, but not like tens millions. So in these cases, we have only the IMSI and PICSI procedures, which can be offered to patients. And as I said, we can combine them, but sometimes in this male factor patients, it is important to understand that we sometimes cannot find the sperm in the sample at all, which has the best quality. Sometimes it's like when you have all like from the old Greek mythology, when everybody will be blind, the man with one eye will be the king. So sometimes what we can do is to find the best looking sperm from the sample, but when compared with the atlas morphology, how the sperm should look like, this sperm will be not good enough compared to the normospermia. But sometimes in the sample there is nothing better. So our goal sometimes is to find the less defected sperm, or like the less damaged sperm from whole sample. But when the male factor is strong, and there is big issues with the quality of the sperms, sometimes we only have to try to find as less damaged sperm from the sample, use them, and wait if they will be good enough to do the fertilization, do the development to the blastocyst. And sometimes we can, of course, repeat the cycle, do like 2-3 cycles, but sometimes it ends with the donor sperms, because sometimes the male factor is so strong that we don't have any methods how we can improve the sperm. We have to work with what we have, and then we can choose the best from what we have in the beginning.
Perfect. Thank you so much for explaining this to us. It's definitely a question that many patients ask. So thanks so much again for this. Okay, and there's a lot of information on forums about how embryo glue helps patient. What's your opinion about it or similar products?
The embryo glue was derived that it is really medium, which contains again the hyaluronic acid, because one of the one of the plus of this molecule is that it is quite sticky, and the logic behind embryo glue is that we cultivate the embryo before the transfer. Let's say 2 hours before the transfer, we put it in this embryo glue medium. It will cover the zona pellucida, which is zona pellucida is like the protection armor of the embryo from the outer world, and it can be like so this embryo glue can be sticked on the zona pellucida from the outside, then it's transferred to the uterus, and it should prevent to move the embryo to the cervix or fallopian tubes in opposite direction. So it should a little bit decrease the extrauterus gravidis. On one hand, it should decrease the embryos which can be lost because they will fall to the cervix. But on the other hand, when you see in a microscope how the lining is in the uterus, it is like big tunnels, big spongeous tissue, where when the embryo is placed there is not big movement at all. And another thing is that when the embryo is hatching, which is optimal phase for transfer, and it can be helped with laser assisted hatching, which we will maybe discuss later. The cells itself are really sticky. So if patients ask us what we can do in Gynem clinic to help in the procedure of transfer, I maybe will recommend more do the laser assisted hatching, because when the embryo is going out from the zona pellucida and the cells are sticky by itself, it doesn't need to have another thickness around them. So I'm not really a fan of embryo glue. That's my opinion. When we check our statistics, we are doing Gynem clinic is opened from 2013, and we had this medium from beginning, and we never had somehow bigger or better results with embryo glue. The groups with or without embryo glue is pretty much the same. Sometimes it's like 2% more, sometimes it's like another year is 2% less. So I'm not a fan of it. We have it because many patients ask for it, but if they ask my opinion, I am telling them what I just told you.
Of course. Thank you so much for your opinion as well. Definitely. Thanks so much. And now let me go to the next question about assisted hatching. Anything I should consider? There are clinics using assisted hatching for frozen embryos, and there are the clinics using it for fresh embryos. What is your opinion on that?
Yeah. I am in this field more than 10 years. I started in 2009, and when I was starting working in this field, the assisted hatching was quite new method, and in these days. Before 10 years, it was everybody hoped that this assisted hatching will do extra hiring of successful rates, because the logic behind is that I told before, we can open the zona pellucida, which is the cover, the protection armor sheet of the embryo. We can make the hole in it by the laser, and when the embryo has I'm telling the patient always, it's like opening the door. When you imagine that the embryo is like inside the room, the walls of the room is the zona pellucida, and I can open the door for the embryo so it can goes out without any problem. But on the other hand, truth is that if the embryo will go out and if it will be successful outside of the room, it's another question. So when there was, as I said before, in 2009, this method was pretty much starting in Czech Republic. In 2012, there was made a big study worldwide. The whole world was included in this study, and it was everybody was hoping that there will be better results, better outcomes, but it showed that the results wasn't somehow better. And after this 2012 big study, many IVF labs doesn't make it anymore, or like stops to offering the aesthetic at all. We are doing it. In the frozen embryos, I am recommending it more because I can see some reasons for this. The vitrification or the freezing itself is not really a natural process. It's something which the embryos are not like evolutionary used to, and this vitrification, this freezing process, can little bit affect the chemical compounds and chemical hardness of the zona pellucida itself. So it can happen that after this freezing, the zona can be a little bit harder than in the fresh one. And in these frozen cycles, we are sometimes helping the embryos to get out from the zona pellucida by making the hole, opening the door for the embryo. But on the other hand, again, the statistics even in our lab and abroad as well are not showing any big differences. So in the fresh transfers, I believe that the embryo has many steps before it to reach healthy child in a delivery, and I can help the embryo in the first step to open the door, but I believe the embryo should be strong enough to do it. Like we all did it when we were embryos. We all do this hatching process, and I believe if I will help the embryo with the first one, it will have 9,999 more steps before it, and it has to be strong enough to reach these steps or climb these steps for itself. So in the fresh transfer, I'm leaving this on embryos, and on the other hand, we many times see that the embryos are hatching by themselves in the time of transfer, which is around 120 hours after fertilization. Quite a lot of embryos, let's say 30-40% embryos, are hatching by themselves, and if not, I'm leaving it with the fresh samples, with the fresh transfers. In the frozen transfers, because the freezing, as I said before, can a little bit affect the chemical compounds in zona pellucida, in these cases we are recommending it or like offering more, but on the other hand, the statistics are not showing any big differences.
All right, perfect. Thank you again so much for explaining all the details on that as well. Assisted hatching for sure. And now let me show you the next one, how we choose embryos for transfer.
Yeah. So as I said before, if we do the standard cultivation in a classical 4-well dish in a classical incubator, I only choose, because sometimes happens that after the 5 days cultivation we have only 1 or 2 blastocysts at all. So there is nothing to choose from. When the patient wants only 1 from 2, of course I will choose the one which is faster. Usually the most important thing about developing of embryos is the speed of the development. So when I see that one of the embryo is a bit bigger, which means it has more cells, it grows faster, I will choose it, this embryo. If both embryos are pretty much the same, of course, we are grading the embryos in 3 ways: how big it is, how fast the development is, how is the quality of the inner cell mass, which will form the future child, and how is the quality of the trophectodermal cells, which will form the future placenta. And if I have 2 embryos in the classical cultivation which have the same grading, I only choose one of them. How it really what I find better in the time of the transfer. When I have 2 embryos or more embryos and one of them is the best, one of them is hatching, or one of them has the best potential because of this grading, I always choose this one. But the benefit of the transferring the blastocyst stage embryos are when we have them in the time-lapse monitoring system, as I said before. So in the time-lapse monitoring system, even if I have 2, 3, 4 same looking embryos on the day of transfer, of the minute of transfer. I can play the movie of their development, how they develop these 5 days of cultivation, and I can check the morphokinetics parameters. In the embryoscope, we have artificial intelligence which help us to choose the embryos. They usually choose the same embryo as we do in the lab, but of course, if somebody is not experienced enough, this artificial intelligence can help to choose as well. And so the time-lapse monitoring system allows us to be more sure that the embryo which we choose is the one with the highest implantation potential.
Thank you so much again for answering this question. Let me go to the next one. And so, how do we freeze embryos and oocytes for future use?
Yeah. So I will start again in my like old days, because when I start to do this this job, there was only slow freezing methods for embryos developed in these late years, or like before 10 years ago, and this slow freezing methods was working quite good for the pronucleus, which means zygotes, for cleavage embryos up to the morula stage. In the morula stage, still the embryos survive this process quite with good percentage, but the blastocyst doesn't work pretty good in this slow freezing method at all, and oocytes wasn't unable to freeze at all in these days. Then, because in our field we are quite lucky that a lot of big companies and are interested in, and a lot of money is going to the science focused on IVF methods. So it was developed, this vitrification or fast freezing method, and with this method we can freeze blastocyst stage embryos, oocytes as well. And if somebody is really experienced, because this vitrification process is quite hard on your hand skills and your experience. So it really needs to be taught many years to, let's say, from me, I was really like, after 2 years of doing this vitrification, I can tell that I'm good at it. It really takes many times, many repeating, to be sure that you are doing this in the best way, how it's possible to done, and how it can be done. And but when the embryologist is experienced and he can do this vitrification by hands, it has like 99% of survival rate. The outcomes from the frozen transfers are the same. Last years are the same as with the fresh transfers. We let's say in Gynem has last year the same percentage of frozen transfers outcomes with the fresh transfers from IVF, from the own oocytes cultivations. So in these last days, last years, the vitrification is really major things in the IVF field. Some laboratories or some IVF clinics starts to do only freezing transfers, because sometimes it shows that the oocyte stimulation process can affect the quality of the lining of uterus, and the whole process of implantation can be somehow like shifted by the stimulation. The body is after the stimulation like in some hormone fever, hormone hurricane, and sometimes the lining, the uterus, is not responding how we should expect. So because, as I said before, some clinics, and we have the same, has the same number, same outcomes, and some clinics has better outcomes from the frozen transfers than from the fresh one. So I know that some clinics completely turned off fresh transfers and do only the freezing of the blastocysts and do all the transfers in the frozen transfer system. We don't do this in our lab, but when somebody is not feeling good after the stimulation, after the oocyte pickup, it's better to freeze the embryos and transfer them in the frozen cycles. For the oocytes as well, because of this, like social things, many patients doesn't have in their young age possibility, or they don't want to become mother in their like young ages. So and because these procedures are here, the vitrification is here, we can really freeze some oocytes from the, let's say, 25 years old patient, and when she will came after 10 years in the 35, she will has better results with the frozen oocytes 10 years before than with the fresh one in the 35 years. This is disadvantage that for women, that the age is going against them in the process of fertilization, of fertility. So after 32, 35 years old, the quality of the oocytes is sometimes really getting worse and worse. And when somebody has frozen oocytes from, let's say, 10 years before, it's sometimes better to use these frozen oocytes than the fresh ones. So the social freezing, how it's called, is really common last years, and it's completely understandable. And I believe it's the way how ladies can of that's in some labs. When somebody's starting with these procedures of vitrification, in the first months, years, the outcomes can be a little bit worse, and this machine, this Gavi system, can help the laboratory to get the highest percentage, highest numbers outcomes from the beginning. And we have this machine in Gynem clinic. There are only 2 machines in Czech Republic, and just like hundreds over the world, 100 of these machines. And I have to say that we have excellent results. We had more than 50% pregnancy rate from this machine, and really this is maybe future of the vitrification itself, because it can do the vitrification process every time the same quality every try. So it's really helping to keep the highest level of outcomes from vitrification in our lab.
Okay, fantastic. Thank you again so much for explaining this in so much detail. I appreciate that, of course. Now there's another question coming here. How can we tell that the donor oocytes are the quality ones?
Usually, as I mentioned before, the age of the donor is the most important thing, or not most, but one of the most important thing. As younger the donor is, the oocytes should be better. Of course, in biology, everything is individual. So we have sometimes experienced that one donor with one, let's say, patient works completely fine. They had like 10 oocytes fertilized, and from 10 embryos they had like 8 beautiful blastocysts. But the next time, the same donor, because we are sometimes having these donors 3 to 4 times, not more, but usually not just once. We can see that with another patient who has the same good, like the quality of the sperm looks from the first sight around the same quality, and the result is completely different. There is less fertilized oocytes, less quality blastocysts. So sometimes it needs to be like fitting. Sometimes we have to fit that some donor doesn't work with some patients how we hope that it will be. Fortunately, we have in our lab new possibility how we can see if the oocytes are are ready for fertilization. It's called spindle observation system, because the meiotic spindle is something which it's some structure in the oocytes, which has to be somewhere in the oocytes. I will not explain because it's quite hard to explain it, but sometimes on the normal microscope we can see the oocytes with polar body, which looks that it's mature, it's ready for fertilization. But when you can see the inner quality of the spindle, where the position of the spindle, it can happen that the process of maturation of the oocyte, in the inner maturation of the oocyte, isn't completed yet. So sometimes can happen that you can like inject the sperm in the oocyte, which looks on the first sight that it's mature, but when you have this observation spindle system, you can see that the oocyte will be ready for implantation, let's say in 2 hours. So this is something new which can be really helpful in own oocyte cycles or the donor ones as well, that we can better time we can better find the precise time of the fertilization.
Hello, Dr. Thomas. I cannot hear you at this point.
Now it's
Yes,
better.
okay.
Yeah,
It
sorry.
just froze for a second, but
Yeah,
all is well.
yeah. So I will just finish it that because of this observation spindle system, we can better say what time is the perfect time for the fertilization itself. So it can help us to get more fertilized embryos, more developing embryos, and hopefully more good blastocysts on the transfer for using of fresh transfer or freezing. So this can be really helpful as well.
All right, perfect. Thank you again so much for explaining this one. And now we will go for the next question, last one for our common ones. But of course, go ahead and type in all of your questions. We will get to them right after this question as well. So what is beneficial in our fertility center compared with other ones?
Because I worked in 2 different labs, 2 different IVF clinics before, and both of them was quite bigger than our Gynem fertility clinic is quite like family one, smaller one. I can see the main differences is that the bigger clinics, bigger IVF centers, there is not much time for communicating with each patient. And when you're going to the smaller clinic, let's say to our clinic, but I believe that in other smaller clinic, maybe it will be the same. We are really focused on communication with patients. So the patient has all the time for the questions on the day of fertilization, day of oocyte pickup. Then again, they can ask whatever they wanted to know in the whole developing time, these 5 days. On the day of transfer, we again meet them personally, embryologists personally with the patients, and again tell them the whole results, tell them what we are advising, what we are recommending, have the speech about it quite long with each patient separately. So and what I hear from the patient, they really appreciate this approach, because sometimes they have experience from different labs, different clinics, and sometimes they feel like they are just like wheel in the machine, nothing like important. But what we are focused on is the importance of each patient, and communicating with each patient separately with extra time for everything, which I believe it's much better for the patient, because the whole fertilization process, whole IVF process is important to be as less stressed and in a good psychical mood in this process, because the psychic can really help the result to become pregnant. And when the patient has good feeling from the whole process, then they are like calmer, they are not so stressed about it, and the results can be better, I believe.
Thank you so much for saying that, because definitely communication in the whole IVF treatment is actually very, very important. And anyone here, any of the patients, definitely, I'm sure they would agree this is something important for them to be up to date as well. That's for sure. Thanks so much.
Yeah.
And as I've mentioned, okay, we will now go to your questions. So if you have any questions, just go ahead and type them all in, okay, so that Dr. Tomáš can help you now as much as possible. And let me then start with the very first question, which is right here. Does the camera in the time-lapse incubator or of the embryos taking so many pictures cause any stress to them?
Yeah, this was of course one of the negative thing in the beginning. If it's like photographing the flashes from the photograph from the camera itself are do some harm, some damage to the embryos. But when it was counted how much light they really get, because when we do the classical incubation and because the patients wants to know how the embryos are growing every day, so we are taking the embryos from the classical incubation outside for, let's say, 1 or 2 minutes every morning, check their status, and returning them back. But when you count how many lights or how much light they get from this 1 minute procedure each day, it is much more than from this 10 minutes just small flash of light in the camera footage, which is like just 1 microsecond, like few microseconds. And when you count these times, the time-lapse monitoring system has less light in the whole 5 days together than it is from the normal incubation outside. Of course, if the patients will be not so doesn't need to know how the embryos are developing. If they will be patient for these 5 days and just wait how it will end, it will be better because there will be no light at all in the classical incubation. But this is not how it's working, because every patient needs to know or wants to know, and I understand it, how the embryos are developing. And when you count these times outside of incubator in the classical incubation, it's more than the flashlights in a time-lapse monitoring system. So the harm is lesser than in the classical incubation.
Okay, perfect. Thank you so much for your question and your answer, helping out. Thanks so much. And now let's go to the next question. How long should we thaw blastocysts before transferring?
It's recommended from the developmental companies that the incubation should be at least 2 hours before the transfer. So this is optimal what we are doing. We are doing a little bit more than 2 hours, but not less. Recommended time is at least 2 hours before the transferring. Because some blastocysts in the freezing process, usually the blastocysts are shrinked and by itself. Sometimes some labs doing artificial shrinking. We are doing it. We are not doing this, but the embryos are shrink by itself because of the process of vitrification. And some embryos take some time to re-expand into the fully blastocyst stage. But truth is that some embryos are fine after a half hour. Some are fine after 2 hours. Majority of them are fine after 2 hours, but some of these embryos can take 4 hours, 6 hours to re-expand. So sometimes even after this 2 hours period, the embryos are not fully expanded yet. But there was no big significance in the statistics when we did the control groups with the shrinked or like not fully expanded and fully expanded blastocysts on the transfer. There was no big differences between these groups. So as again, in biology, everything is individual, and some embryos takes more time to re-expand after the thawing process, and some are faster. But recommended time is 2 hours.
Fantastic. Again, thank you so much for explaining that to us again. All right. There is another question right here. So some clinics still have frozen embryos by slow vitrification, but unfortunately not in a cleavage state, only in blastocyst 1. Which chances have such embryos to survive after thawing in a percent?
As I said before, when I was working in the first lab, when there was only this slow freezing methods for blastocyst, we counted then that it was around 30 to 40% of survival rate. and then from these survived embryos, only let's say 30% was successful in the implantation process. So when compared with vitrification, that we have survival rate with vitrification more than 95%, and around 45% of these embryos then are successful. The numbers are much lower, but this is, as I said before, the field is moving on, and before 10 years or before many years ago, the procedures wasn't here, the vitrification procedure wasn't here, and we then did the best we can, but now we have better ways. This is how it is.
Okay, perfect. Thank you so much. And actually, there is a follow-up question from the same patient. Okay, so a blastocyst 6BB has already been hatched. Does it make sense to transfer such embryo?
Yeah, as I said, like the optimal phase for the transfer is hatching or hatched embryo, because in a uterus, what happens normally, like in a nature, is that the embryo is going through the fallopian tubes, falls into uterus. It has to hatch by itself, and then only the hatched cells can do the implantation. So when we have two embryos in the lab, one of them is, like, let's say, completely hatched like this, because 6 means that it's completely hatched, and one of the second embryo can be, let's say, 4AA, so it's like better quality but not hatched. I will choose 6BB, because the chance that the other one will be not hatched at all, even if the embryo looks perfect, 4AA, we never know if the development will continue, if the hatching process will continue, if everything ends fine. So in this embryo, when we know that the hatching process is already done, so it has maybe better chance to be transferred and to be successful than let's say slower embryo with maybe better quality. So 6BB for transfer is make completely sense.
Okay, perfect. Thank you so much for your advice on that as well. And now we have another question, a bit longer, just so right here. If Embryogen is used until day 3, does BlastGen need to be used to culture up to day 5? What is the difference between both culture mediums? I'm asking because in a recent cycle, the clinic only had Embryogen, not BlastGen, and none of the embryos we had at day 3 made it to day 5.
Mm-hmm. The difference between BlastGen and Embryogen is most because every embryo needs something else in the cleavage procedure and cleavage time, and something else in blastocyst stage. We have in our lab one-step medium, which means it is one, because for the time-lapse monitoring system, it's better to have the embryo still in the same conditions, not to taking it out, because it is benefit of this embryoscope that we don't have to take the embryo out from the cultivating conditions. And for this time-lapse systems was developed this one-stage medium, which means that it doesn't need to be changed over these 5 days. The mediums are enriched with the lactate, pyruvate stuffs, which are which embryos needed in the one phase, and sucroses, glucoses when they need in the second phase, and all the stuffs are there in the beginning. In the Embryogen and BlastGen, which they are enriched with some cytokines and growth factors as well. They are growth factor cytokines, and also these chemical compounds which are important for the metabolic activity of the embryo, focused on the stage of the embryo. So Embryogen is focused on the cleavage stage, BlastGen is focused on the blastocyst stage. I don't really think that the reason why the embryo stops from the day 3 to the day 5 was because they don't have BlastGen. The Embryogen medium should be fine enough for reaching the blastocyst stage as well. So it can, of course, help the embryos when the BlastGen will be there, but I'm not sure that if there will be this BlastGen medium for the second 2 day or the second part of the development, that it will definitely end with nice blastocyst. Maybe the problem is something else, because what is known is that on the day 3, between the day 3 or 4, the male factor, the genetic information from the sperm, is involved in the process of development, because the oocytes and the embryo works that the oocytes is the biggest human cell, and it's filled with these like building blocks, metabolic stuffs, compounds which they need to be there for the development up to the 3 days of development. So usually the embryo is growing to the day 3 from the things which are in the oocyte, and then it needs to build more stuffs to continue in the development. And because the genetic information in the oocyte was different, it was the mother genetic information, but the embryo has new genetic information because it's half of the mother and half from the father. So sometimes can happen that the embryos versus their development or stops completely their development on day 4, because the genetic information of the embryo starting to show it the quality of itself, because the new building blocks are done from the new genetic information, which is combined with mother and father as well. So when the embryos versus their development or stops their development after day 3, it can be because of the poorer quality of the embryo, because of the poor quality of the genetic information in male. So I cannot be 100% sure that the embryo stops in development because of this only embryogen medium. This second factor, which is the genetic information, can play a strong role as well. So you of course have to try it again. Maybe with the Blasgen will be better result, but maybe it will be with the Blasgen the same, and the problem can be in a male genetic information.
Thank you so much for your question and explaining yet again for us all the details. I am sure it was very useful for all of you. We will be slowly finishing. So if you have any questions, just go ahead and type them all in so we can help you out as much as possible today. And there's another question which is quite interesting. If I choose an African donor, can it happen by mistake that the doctor used different Caucasian donor?
It shouldn't happen, of course. We in Czech Republic have really strict rules on the quality management in the lab, and we have many like set points, many witnessing systems how we should be how we should be sure that this mistake will not happen. Of course, because in the lab there are not working only machines but humans as well, and human then can always do the mistakes. Even in Czech Republic, I know that there was one mistake of this kind, that there was some switching of donors in the IVF treatment. So I cannot tell that it is 100% sure that it will not happen, but I never experienced it. We have many systems how we should prevent it, and many witnessing system how which should like be not possible to do the mistake. But as I said before, humans are humans, and mistake can be done, of course.
Okay, thank you so much on commenting on this particular topic. Well, definitely, it's good to know that there are some systems that they are able to, of course, control it. I mean, this is definitely
like this is the biggest issue. So like when some clinic will do this mistake, it can end up with end of this clinic. So
yes, that's true.
this is like the most important thing, that we will do no mistakes in our lab. So we have like everything signed, everything twice checked. We are working in a lab, more people, so we are always looking after each other. Everything is commented, everything is done in some computer matching systems. Everything is so strict and precise that I believe we are not able to do the mistake. But I don't know how it works in different lab. I worked only in Czech once, and what I know is that in Czech law we are maybe the strictest in the whole Europe, as I heard, because we have a quite hard Ministry of Health and bureau which is like checking us, but this is for good for the patients, because but on the other hand, as I said, I heard that in one Czech laboratory the mistake was done as well. So nobody is perfect.
Of course. Thank you so much again for your question. Definitely interesting one, and for your answer as well. All right, let me go to the very next question here. The best sample of my husband's sperm is from 12 years ago, which was slow vitrified when he was younger and will be used with 24-year-old young donor. Will their sperm be a problem because it was slow vitrified, as we don't want to use recent frozen samples as the quality is not as good?
The sperm is, or I don't know, like the slow vitrification is maybe not correct. It will be slow freezing, because the vitrification is the fast freezing process, and in the sperm sample they are usually not vitrified. They are even now still freezing by the slow freezing method, and because the sperm is much less complicated cell than it is oocyte, in the sperm the slow freezing method still works fine. So even in our lab we are using slow freezing method for sperm freezing, and of course, if I should compare this fresh sample with the frozen sample, with the same quality, the fresh will be always better, because the freezing is not, slow freezing. The freezing is not something natural. But if the quality of the sperm was much more better before 12 years than it is now, and you have frozen sperm 12 years ago with a good quality, the chances for good results will be better with this frozen sperm from 12 years 12 years old, because the time in the cryotank isn't really something important. When the sperm is freeze, they can be freezed for like 50 years, 100 years. It's for them the time only slows. So let's say if you think about it, that 1 minute for the sperm in our temperature is like 1 year for the sperm in the cryotank. So after 12 years of the freezing stage, they are only 12 minutes later, like if they will be fresh. The time is so slow for them, so it doesn't really it isn't important how long they are freezed. And if they were better quality than they are now, the fresh sample is now, it's definitely better use these frozen ones.
All right, perfect. Thank you so much again for explaining that to us. It's definitely very interesting that we are still able to do all this.
Yeah.
Thank you so much. All right, now let's me go to the next question for you. How many hours after ICSI or IVF do you check for fertilization? Is it like 18 hours? What happens if you missing the European stage, since it doesn't last long?
Yeah, it's usually around these 18 hours, 19 hours, but sometimes it can be visible after, let's say, 5 hours, 6 hours. It depends. But this is another plus of this time-lapse monitoring systems, time-lapse incubators, because we are putting the oocytes, or like the fertilized oocytes, not embryos, because we don't know if the fertilization will be there, in the time-lapse monitoring system just after the fertilization, just after the ICSI or IVF. So we can see if there is the pronuclease, even if they will be after 5 hours, 6 hours, 18 hours, doesn't matter. If they are in the classical cultivation, usual time for check the fertilization is these 18, 19 hours. But it can happen that sometimes we don't see in the classical incubation the pronuclease. And what is the risk of it is that sometimes can happen that there can be more pronuclease, like let's say 3. In the IVF, it can occur quite often that 2 sperms will enter the oocyte, and it can be a triploid organism, which is completely bad for transfer and bad for everything. It can be really bad outcomes, some syndromes and some things you don't want to have. So this counting of 2 pronuclease is really important. So when we have, let's say, because sometimes some patients doesn't want to have these time-lapse systems because they are extra paid or something. So when we are sure that some embryos has 2 pronuclease and some we didn't see, even if they are developing well, we always choose these ones which we were sure that we saw 2 pronuclease. On the other hand, sometimes can happen that there can be some mistake only in the visualization of the pronuclease. I had experience that we had one patient with one embryo which has only 1 pronuclease, but the development was quite fine till the blastocyst. We did the genetic screening, so I biopsied this blastocyst as well, just to know how it really is. And we find out that the blastocyst was completely fine, completely euploid organism. So sometimes can happen that we see only, let's say, 1 pronuclease. We take this oocyte or embryo to the other well, and we are not using it at all, but it can be completely healthy organism. So there are some tricky things in this pronuclear visualization. There can be mistakes in the visualization, but not in the genetic information. But of course, if you know that some oocytes or some embryos you were able to see 2 pronuclease, it's much more rational to use these embryos than the embryos that which wasn't which you didn't see the pronuclease at all.
Mm-hmm. Fantastic. Again, thank you so much for explaining this and answering the question. As I mentioned, we will be finishing very, very soon, but there are some questions left. So let's get to it. Let me start with this one. How many hours after IVF insemination do you transfer the inseminated eggs in the time-lapse dish?
The IVF insemination is a little bit hard with the IVF insemination because for the IVF insemination there has to be cumular cells around the oocyte, because without these cumular cells the sperm is not capacitating and the acrosomic reaction will be not there. So in these cases we are sometimes doing this after the 18 hours the next day, and sometimes we see the pronuclease. We are trying to do it as soon as possible, but it can happen that we are missing the pronuclease in these IVF procedures. But truth is that in our clinic we are doing 99% of ICSI. So because I had some troubles, some issues with patient, it was like maybe 3 times, 4 times when patient has quite good quality sperm, many oocytes. They choose to do IVF fertilization, but the result was like from 15 oocytes, let's say, was only 3 fertilized. And the patients was sad, I was sad, and it was not optimal. And I know we have fertilization rate in ICSI 85%. And I know that when I will put the good-looking sperm in the oocyte, in the 15 oocytes, I will definitely have at least 10 fertilized embryos, 10 embryos from the ICSI procedure at least. So I am really recommending patients who are undergoing this IVF treatment, when they came to the stage that they need this artificial help, let's do it properly. Let's do it with maximizing the chances. So we maybe did 1 time IVF insemination in time-lapse, and we placed the embryos there the next day, which was maybe after 15 hours.
Mm-hmm. Perfect. Thank you so much again for that. And we have another question, which is actually something that comes back quite often as well, about mosaic embryos. So do mosaic embryos happen often? What is your opinion about such embryos?
Yeah. Mosaicism happens quite often in human embryos. This is quite normal phenomenon, and this is one thing which I don't really like on the PGT screening. I recommend to our patients do the PGT screening only in cases where they have some monogenic diseases, some inherited diseases, when they have structural problems like translocation or these stuff. But just for checking the quality of the aneuploidies, and because this can happen that we have only mosaic embryos, and it doesn't really mean that the embryos are bad or good from this result. So this is field which is still work on it. There is big science work done on this mosaic embryos right now, and I believe maybe in the future the PGT aneuploidy screening will be less used, because the information get from this PGTA sometimes can be confused. Sometimes we can throw away embryos which can be completely fine and completely worth of try, because they can be successful with good quality and healthy child, and sometimes not good numbers of euploid embryos are derived from this PGT testing. So it's really important to know why you are doing this. Of course, if you are 42 years old, this is reason why to do it. Or if you have some miscarriages, this is reason. But if patients is only 32 years old and want to be sure that the embryos will be not aneuploidy, I am really recommending them not to do genetic testing, because the negatives and the mosaicism is one of the negative of this procedure is maybe bigger than the positive of this procedure. So mosaicism happens. I don't know what really think about it. I believe that sometimes the embryos can be completely fine, but on the other hand, they can be completely wrong, and we really don't know.
All right. Thank you so much for your opinion on that as well. Thank you.
Yep.
And I believe it is our last question for today, but if you have anything else to add, just go ahead and type it all in. And now it's actually about the known donors in the Czech Republic. Surrogacy, I know, is possible. Known donors, no, I guess. But if you could comment on that.
Yeah. We have only unknown donors possible in Czech Republic, and surrogacy is not illegal, but it is not legal. So it's like in some like gray field, but because it's what is not illegal can be done. So we are doing this even in our clinic sometimes, but it has to be strong reasons for doing this. I know it maybe in some other Czech clinics they are more like more for the surrogacy. We are not like the fan of it, but it is not illegal, so it can be done in Czech Republic. And the known donors, there is a big communication, big discussion on European field in the European Union. Maybe it will be in a couple of years opened. This open identity maybe will be everywhere, even in Czech. We will see. But in this time, we have only unknown donors, and surrogacy is legal here, or like not legal, but not illegal.
All right. Thank you so much for for commenting on that as well and explaining to us a bit on that. Actually, there is one more question, so let me go ahead with it. Do you have guaranteed live birth programs at your clinic?
This is really, many patients, and we are focused like let's say 60% of our patients are abroad. Many patients are in Czech Republic only for the time of the treatment, which is 1 week, and of course that we will be happy that we will know and we can somehow assure that everything will go right. We never can tell how the patient will live and will do their pregnancy time, and we never can be sure if there is some, let's say, miscarriage, which is after 12 weeks. We are counting clinical outcomes, clinical pregnancies, which is for the clinical pregnancy is made by the heartbeat. It's around 10th week, and after this we are thinking that this patient is pregnant, and if there is some miscarriage later, we never can say that it is because of our job or because her living, her lifestyle, whatever. So we don't have anything like live birth programs because the patient should be in our clinic for 9 months, and we have to be, checking him every day to be sure that he is treating how it should be treating. So this is really something we cannot somehow do.
Okay, thank you. so much for this as well. Okay, and as I mentioned, we this was our last question for today. Okay, I guess there is one more thing about surrogates. So just give me a second. Okay, let's have a look. If you could comment on that, perhaps. But using surrogates which are screened by your clinic, so you have.
Yeah. Like as I said, we have a few cases with the surrogacy, and it's that the patients usually come to our clinic. They have some reasons for the surrogacy mothercy. It can be one of the main reasons is that they have some problems with uterus, the patient, so they are unable to deliver the child by themselves. And in this phase, they came. We are not like companies who can find the surrogacy mother. But when the patients come to our clinic with the surrogate mother, which they find somewhere else, we don't want to wear, and we don't want to know what's their deal, let's say. So
All right.
when they came to our clinic, we will screen her. We will do the test to the mother. We will see do the ultrasounds, do everything. If the uterus is fine, and if it's all fine, we can do the transfer to the surrogacy mother. Yeah.
Perfect. Thank you so much for answering this one. As I mentioned, that was our last question, in fact. But I would already like to thank you for explaining all the details on all the techniques, etc. It definitely was very useful, and I can honestly say that it was not only for me very interesting, and as you can see. Thank you.
Thank you.
Those are the comments from the patients. Thank you, Dr. Thomas, for
Thank you.
such a fantastic webinar. It was a pleasure to watch.
Thank you.
Happy
You're
to
welcome. I
have
was happy
you
happy
here.
to answer whatever you need to know, and wish you good luck in your life.
Perfect. There's another one. Most helpful webinar. So a lot of helpful information,
Thank
a
you.
very knowledgeable presenter.
I'm
Fantastic.
happy it was useful.
Yes, definitely it was. So huge thank you. There are like more thank yous, of course, right here. Thank you all for being with us again and again, because I know that you are just taking your time to join us and just find out as much as you can. And you are, it's great to have you all here. Of course, let me just invite you straight away to our next webinar today at 8 p.m. UK time. If you have time, then go ahead and join us. We will have another webinar with Dr. Diana Obydniak from St. Petersburg, from Ava Peter Clinic. So I would love to see you there. And again, let me just remind you that all the events you can find on myivfanswers.com. There are so many of the webinars there. I'm sure you can find anything on any actual topic on IVF, etc. So go ahead and if you are looking for some answers, you can definitely use that site as well. And once again, Dr. Thomas, it was a great pleasure to have you here. Thank you for supporting our Stronger Together initiative. It's been really great to have you.
You're welcome. Thank you very much.
Thank you. All of you have a great evening. And well, I guess I will be back here very, very soon. Bye-bye. Thanks so much. Bye.
Bye bye. Bye bye.